Gelpoint insertion. After creating a 2 to 2.5 centimeter vertical or semilunar incision in the umbilicus, the abdomen is entered similar to open laparoscopy. The gelpoint device has a string attached to one end of the inner ring, which is used to remove the ring at the end of the case. The purple inner ring is aligned so that the string is facing the pelvis. We have found that lubricating the ring with gel or saline facilitates insertion. The incision is elevated with a retractor with insertion of the string side first. It is important to confirm that the ring is completely inside the peritoneal cavity and not between the fascia and the peritoneum. We then elevate the outer ring to take out the excess material. You may want to consider checking to be sure that the bowel is not caught between the ring and the abdominal wall. This can also be done with the scope when it is introduced. The ring is then folded inward using 2 sets of hands. If you're not familiar with these retractors, you can see that the device creates a nice symmetric opening which facilitates removal of the specimen at the end of the case. This is a big improvement over some of the other single port devices. The cap is then oriented to allow the assistant to manage the insufflation port. Insertion of the trocars should occur around the perimeter of the logo, but not too close to the outer ring. Placing the trocars near the outer ring will create too acute of an angle to the abdominal opening and can also cause the ring to interfere with the range of motion of the instruments. Typically, we like to place the trocars in a triangle around the ring so that the assistant can manage the scope while the surgeon manages the other 2 ports. As you can see, 1 trocar is used for all of the port insertions. Once the trocar is inserted through the gel, the locking ring is pushed down to lock the port into place. If you dislodge a port or choose to replace a port during the case, it is important to remove the ring first to reduce injury to the bowel and surrounding structures. The cap is then placed over the outer ring and locked into place. Insufflation occurs actually outside the abdomen, creating a domed effect in the gel cap. This creates more separation between the ports. One modification that helps with smoke evacuation is to add a 4-way stopcock to the insufflation port. It is important to remind your assistant not to allow the abdominal pressure to fall below 8 millimeters of mercury to minimize loss of exposure of the structures and minimize risk of injury. We use a 30-degree Olympus endo-eye scope. As you can see, the cable comes out of the top of the scope, which keeps it out of the way of the other instruments. Some other options are to use a bariatric length scope or a right angle device to move the cable out of the way with a standard 30-degree camera. Olympus also makes a flexible tip scope, which allows for even more separation between instruments and visualization of structures. By angling the image, you can move the scope away from other instruments. Here we are placing the outside of the scope down to angle the tip of the scope near the anterior abdominal wall to look down on the pelvis. When introducing instruments, it is important to angle the instruments towards the abdominal opening. In this video, the surgeon is operating the scope in one instrument. More frequently, we have the assistant operate the scope so that the surgeon can operate the other 2 instruments. The instruments are typically crossed in the abdomen to create separation. Thank you.